Hey everyone, I wanted to record a final summary for our imaging course. We'll first talk about the final week of discussion involving cardiopulmonary imaging, specifically related to DVT. I think hopefully everyone recognizes the importance of DVTs in physical therapy practice. Really, it cuts across all settings: inpatient, outpatient, rehab, even pediatrics. So it's a very important topic, and the Wells rule does a really nice job of helping PTs to understand the probability of having a DVT and then the appropriate imaging studies that you might consider. It seems like in our country, most of the time that people go right to the Doppler ultrasound. For those lower probability DVTs, it's recommended you do the D-dimer test because that's actually a low probability combined with a negative D-dimer is very sensitive for ruling out. But it seems for whatever reason, we tend to go right to ultrasound. If anybody's suspected of having a DVT, that tends to be the trend in our country. Probably have to look into the cost effectiveness of that. What would be the cost effectiveness of everybody getting an ultrasound versus using the Wells rule to determine low probability go D-dimer, everyone else get the ultrasound. So that would be an interesting study to do. But regardless, I think everybody understands the importance of the DVT. Use that Wells rule. It doesn't seem to have as much application in the acute inpatient setting because there's another number of circumstances going on there. Patients are usually closely monitored in that setting anyways. A lot of them are on anticoagulants. So it seems to be mostly applicable to the outpatient phase or maybe acute rehab as well. So an inpatient, I think there's enough folks monitoring, including you guys have talked about that, and I'm not sure if you can apply that rule as well as in later stages. So just kind of keep that in mind. And regardless, we have our D-dimer test, which is just a lab test that's good for ruling out low probability in anything where it's more likely. We have our Doppler ultrasound, our ultrasound with compression. And really what they do with that is they do an ultrasound and look to see if the vein is compressible. If it's not compressible, that's suggestive of a clot. Some of you guys shared some really good stories where you're able to pick up some DVTs. And that's why I think this is such an important topic, because you will, more than any other red flag, likely see this in your career as a physical therapist. So great job on the discussions once again. And I'd say for the entire course, you guys have been really engaged in the discussions, supporting your classmates who posted, you're asking good questions, you're following up, you're sharing stories, sharing new research. So if anything you gain out of this course, it's the ability to use the literature to guide your practice. There's so much information coming out all the time on imaging, so you really want to use the resources that we talked about. In particular, ACR criteria would be my go-to resource for imaging stuff. And then, of course, PubMed, if you're looking at something that's new, that's not included in those ACR guidelines. So this was really just a smattering of the stuff that we could potentially cover in this course. But as physical therapists, we do not need to be experts in imaging, but we at least need to have a baseline level of knowledge to determine when an imaging is required and potentially which image would be necessary. The other thing is I think we need is the ability to understand how imaging, our patient's imaging study, will play into our physical therapy management. So I work on the outpatient side, so many times my job is to help talk that patient down off the ledge when they get an imaging study and they think it might be really scary or potentially that they can't get better. When we're talking about like lower back pain and things like that, I spend a lot of time educating patients on what really those imaging findings mean. So we see that across a host of musculoskeletal conditions where many of the things that we're going to see are normal changes or age-related changes that you might see just as you get older. And then I think the APTA is going to continue to push for PTs being able to order imaging studies. That was a motion made in the House of Delegates. They're going to start looking at legislation for that. So kind of stay tuned for some of those developments. And that's why it's good that you guys getting your DPT so you have this information. So when that time comes, you feel comfortable in possibly making those decisions. So great job on this course. I think from the last time I checked, I graded everyone's discussions. You guys were all up to date with that, so awesome job on that. Just about everyone's done with their final examination in cardiopulm. If you're not done, try to get that done over the next week. Your article critique papers are all graded. So pretty much the course is wrapped up, and you should be starting your pharmacology course this week or next week. If you have any questions, please let me know. It was great to sort of get to know you guys over this last 7 weeks. I really like the engagement. You guys are kind of showing your leadership in doing this DPT, and also in your great participation in the course. So it was a great time teaching it, and I look forward to hopefully meeting you one day in the future. And the other thing I would say before I sign off here is any of the information from the course, make sure you download it so you have access to it in the future. If you have any questions, shoot me an email.